that if you can do it, it will maximise your chance of securing a mock interview with us. So without further ado, I'll hand it over. Is it Matt, are you going first, or is it Hannah?
I'll be going first.
Okay, great.
Hi everyone, so today we're just going to talk through the clinical section of the interview, focusing more so on London. So the sort of structure of the interview that you're likely to get is you'll get your clinical scenario, but you'll also get an abstract for sort of a critical appraisal. Now, the way the timing works is you'll usually get 15 minutes of preparation time, and that's split between clinical and the sort of critical appraisal. Now, it's up to you how you spend that time, but we would advise sort of 7.5 minutes for the clinical section. Then when they actually move on to asking you the clinical questions, that can range from about 10 to 20 minutes long, but I think most cases it is about 10 minutes. Now, the reason why there is a big focus on sort of the clinical station, which is your A to E scenarios, is because as an academic F1, you will have less clinical exposure. So whether that's 4 months that you're not on the wards, or you get 1 day a week that you're not on the wards throughout the 2 years. So they're really just checking that you're going to be a safe F1 without having that extra clinical time that everybody else has. In terms of what these sort of stations look like, it's about you gaining information. So we'll talk a little bit about relying on other members of the team. You need to know how to prioritise different patients and which patients you'd go and see first. You need to justify this in your assessment. And then finally, you need to safety net any patients that you won't be prioritising to see first. Now, the main crux of the station is doing a fluent A to E assessment. So I'm sure a lot of you have practiced doing that within medical school. What we would say is, what we would advise is whenever you get a scenario presented to you, have a few different differentials in your head. It's not necessary that you sort of predict the correct differential, but as long as you're safe and you work through the steps, you shouldn't get penalised for that, but always have backup sort of differentials because you can get asked what those could be and why. And then another thing that you should expect during the scenario is a bit of a curveball. So they want to test your adaptability. So you might be dealing with a patient perfectly fine within an ATE scenario, and then they suddenly deteriorate. Expect that to happen. It may or may not happen, but it's just sort of testing whether you can keep your cool and adapt to that scenario. But again, just carry on with the assessment, and we'll talk through the different steps of that now. Okay, so we'll be going through the clinical prioritization, the ATE assessment, which you've probably come across in medical school. And then Matt's going to talk about the ethics side of things as well. So looking at capacity, DOLs, confidentiality, and then finally, what is quite sort of neglected in the interviews is the SBAR handover. And that really just helped to put you across really well. And it's just really important for F1 and F2 as well. And we'll be doing examples throughout the presentation and getting you all involved. So hopefully we'll ask for volunteers. If not, we might have to pick on a few of you. But I just want to emphasize that it is really useful to practice these scenarios. We would recommend it. Okay, so first of all, what we're going to talk through is clinical prioritization. Now, what I would say is that there should be 3 main things in mind. And if you use this approach, I think you can come across really well. So the first thing that you want to do is acknowledge that you're part of an MDT. And what this means is sort of relying upon the nurses, other doctors that are present, and any other member of staff for what particular need you might need them for. So acknowledging that and saying it in the sentence that we've put on the slide, so reflecting that you all have a shared priority for this patient, that's a really good thing to sort of set the scene off before you go into the scenario, and gives you that little bit of thinking time as well. So I've just given some examples of things that you can say. The next thing that you want to do is sort of gather information, and that's something that you can start doing before you've even gone to see the patient. So that's things like asking the nurse who's bleeped you for an SBAR handover, that's sort of asking them to take a full set of observations, and if the patient is someone that you're not going to go and see initially, you can ask them to sort of repeat those until you arrive. That's a good way of making sure that they don't deteriorate. And then things like taking a full history or getting a collateral history, that doesn't necessarily need you to take it. And then finally, think about what applies to the scenario specifically. So look at things like age, sort of mental status, and think about sort of the concepts like capacity, confidentiality, and deprivation of liberties. And I think if you use all of these sort of 3 categories, it really helps to, well, it's just a really good approach to sort of these scenarios and making sure that you cover all of the relevant points.
Sorry. It's not letting me move on. There we go.
That's all right. Okay, so what I'm going to do is give you all a couple of minutes to read this scenario, and then I'm going to ask one of you to just sort of talk through the 3 things that we talked about. So just sort of what would be going through your head when you're trying to think about answering this question. So I'll give you all a couple of minutes now, and then if one of you wants to volunteer, or if not, we'll pick someone to do it. Okay, so we'll give it a read, but would anybody like to volunteer to do this? So we just want to talk through sort of the things that you're thinking about when you're trying to prioritise any patients. Would anyone like to volunteer? Or I can pick someone. Okay, let's have a look. Is Molly here? Molly, do you want to give it a go? I just want to reiterate that, you know, actually trying examples of it is a really good way of learning how to do it, and we can work through it together. So does anybody want to volunteer?
Hi.
Yeah, Molly?
Molly.
Yeah, Molly, yeah.
Hi.
Hiya, Molly. So we can just talk through sort of the things that you're thinking about when you're trying to approach this scenario. So we don't need to do the A to E bit, just sort of thinking about, we could go through each patient and what you're thinking about.
Yeah, so I just read through each patient and sort of was thinking, I was sort of going with the rationale of like which would be most life-threatening in terms of needing immediate help.
Yeah.
So reading through all 3, I don't know if this is right, but I think it was the last one that stood out to me as needing sort of like intervention. And then obviously the second one as well, there's like the issue of them saying that they're going to leave if they're not seen by a doctor. Yeah.
Yeah, okay, so let's sort of prioritize it 1 to 3. And so we could work through, there are different ways of doing this. There's not a right or wrong way, and there's not sort of a right or wrong patient to go and see first either. As long as, like you've done, is justify why you want to go and do it, that's sort of what they're looking for. So just seeing whether you can use clinical reasoning. So which patient would you say, let's work from the least priority, and then you can spend more time on the one that you really want to go and see first. So which patient is your least priority at this moment?
So I think the first patient sounds like they have already been seen by an SHO, which suggests at least that they're like potentially semi-stable. They haven't handed them over in a way of saying like you need to see them urgently. So what I can take from that anyway.
Okay.
Guess like some of the things I was thinking about was like appendicitis, or possibly if it's a female, like ectopic, etc. So I kind of thought that maybe whilst I saw a different patient could see if the nurse could do like a pregnancy test or something on that patient at least.
Yeah, so that sounds good. That's sort of another way to start off that one, is to say, before you even gone into talking about any of the patients, just recognise, like we said, that you're part of an MDT, which you've done, and so that you'll rely on other members of the team. So that's a really good suggestion with the nursing staff. Okay, so then who would you go and see? Who would be your second patient to go and see?
So I think both of the next patients have like a valid reason as to why to see them. The patient who's threatening to leave if he's not seen, like that's really the main reason, which is obviously like very inconvenient, but isn't maybe as life-threatening potentially as seeing the patient with their high blood pressure, which is why I'd say I'd go and see them first.
Yeah. Okay. And then which patient would you want to go and see first?
So the patient with the really high blood pressure.
Okay. So you've decided that that's sort of your highest priority. What can you get the other members of the MDT to do in the meantime? So you've talked about what you do for the first patient. What could you get the members of the team to do for the second patient before you have time to go and see him?
Possibly see if we could get him some pain relief.
Yeah.
And then just some obs, etc. on him, and let him know that there is a doctor coming to see him soon.
Yeah.
I guess double check there aren't any F1s that can go and see him as well.
Yeah, no, that sounds really good. So I think what you did a really good job there, Molly. Thank you for somewhat volunteering. So yeah, the things that we would say to do is to start off saying that you're part of an MDT, and then go into the scenario how you did. So there's no right or wrong answer. I think so the first scenario, it is the main differential would be appendicitis, like you said. So with that one, I would potentially go and see that patient first, just because it is quite an acute scenario. And the SHO might not have gone and properly reviewed. So maybe what you could do is ask for an SBAR handover at that time as well, to just give you that extra bit of information.
Okay.
For the second patient, so the patient with the colorectal cancer, I think your suggestion was really good, because the main thing that he is complaining about is the leg pain. So he might already have some paracetamol or some analgesia on his drug chart. So I think, again, gathering that information and then asking someone to prescribe him that. Also, perhaps look at things like his age, and you're considering the ethics side of things. So does this patient have full capacity? Has a capacity assessment been done on him as well? And then finally, so the nurse who bleeped you about the patient with the really high blood pressure. So with that, we could get some more information and ask for sort of a full SBAR handover about any symptoms that the patient has been displaying. And before you actually go there, you could ask for some investigations to be done, like blood pressure, ask if there's been any vision changes, and do a urine test as well. So as you can see, there's quite a lot of things that you can do without going and seeing the patient immediately. But you did a really good job. Thank you. Should we move on to the next slide?
Hannah, we have one question in the chat if you want to answer it. Somebody's asked, would you consider Cordo Aquina due to his background of colorectal cancer in the second patient?
Yes, so you can literally suggest anything. That's a really good suggestion. And as long as you justify why you're thinking that, that could be the reason that you go and see that patient first. And if that is the case, you would sort of ask, has the patient displayed any other symptoms? Are they able to feel their legs? Has there been any incontinence? So you can go down literally any route as long as it makes clinical sense and you can justify it. Again, with that, there's no right or wrong answer.
Great, thank you. And one more question. Would you worry about the BP of 200?
Yeah, so with all the patients, there is something to worry about. So that's the point of the scenario, the fact that all of the patients need care. They all have a level of concern, and you need to decide which one is your immediate concern. So with the blood pressure of 200, you would be thinking things like malignant hypertension. But again, with that sort of diagnosis, you'd want to know whether the patient has any symptoms with that. So I'd want to get a bit more of a history before I sort of run over there and see what's happening, because I would personally go and choose the patient one with the appendicitis, suspected appendicitis, because I'd be thinking we need to get them sort of prepped for surgery if that is what we're thinking. But again, as long as you justify why you want to do what you want to do. There's no right or wrong answer with it.
Thank you. And just a follow-on question from that, I think they're asking, the news is only 2, so why are they still a concern?
Yeah, so you could sort of say the news isn't as high for you to rush over, but you're still concerned about the blood pressure. So it's a patient that you will go and review after reviewing another patient. Also remember that whatever information they give, it usually serves a purpose. So as long as you use it within your justification, you should be fine.
Great, thank you. And just to add on to that, some things don't trigger a news score actually, which is weird, like really high blood pressure.
Yeah.
So sometimes the news isn't everything, and you might want the specific observations.
Yeah, exactly. So I think the 2 bits of information that you can always ask to make sure that your safety netting is asking for an S-bar handover and then a full set of observations, and then just ask them to be done periodically until you arrive. Yeah, okay. So now we're going to move on to sort of the A to E scenario. So after you're done with prioritizing, then what they'll usually do is you'll sort of go through an A to E scenario of your highest priority patient, or they might choose sort of a different patient because they might have reasoned the highest priority to be another patient. If that's the case, don't worry that you sort of chose the wrong patient. That's absolutely fine. There's no right or wrong. They just want you to focus on the one that they're saying now. So with airway, I'm sure a lot of you have been through A to E a lot in medical school, but we're just going to do a quick run through. So with airway, the first thing to do is to sort of talk to the patient. If they're speaking in full sentences, you know that they can verbalize and that their airway is most likely patent, so you can move straight on to B. But in a lot of cases, that isn't what is happening, so you'll need to go through, so you look, feel, you're listening, any investigations, and then sort of any interventions at that point. So first of all, oh, can we just go back? Yeah. Could we just go back to the previous slide? Is that all right? Thank you, Matt. Okay, so first of all, things that you're looking for are things like any physical obstructions, that's like your vomit or if someone's choking on something. Then looking for any signs of tongue swelling or lip swelling. So you're thinking things like an allergic reaction. So with that, look for a rash, which some people sort of miss in airway. Then you can also consider things like any sort of basal skull fractures whilst you're looking around the head and neck region. This section is sort of your doctor's ABC, so you're feeling for breaths, you're listening for any added airway sounds, any stridor, any wheeze without using your stethoscope at this point. And then the main sort of interventions that you're going to do are your quite simple ones in doctor's ABC. So your head tilt chin lift, you might consider a jaw thrust if you're thinking a C-spine injury. You might need to use different tools, so using suction and forceps if there was any physical obstructions. And then airway adjuncts are something that I think you need to know quite well for this interview, because they can ask you about the sort of nitty-gritty details. So I've done a slide on that we'll talk through in a moment. Also, if you do have major concerns with airway, I think don't hesitate to say that you would call 2222 for an anaesthetist to come and intubate. And even if you don't think it's relevant for that scenario, I think it's a nice way of just sort of showing off your knowledge and saying, if the patient's airway was to deteriorate, this is what I would do. Yeah, so if you could move on to the next slide, please. Thank you. Okay, so airway adjuncts. What I would advise is that you all sort of read through the different airway adjuncts. Now, there are your different ones. So you have your nasopharyngeal, oropharyngeal, eye gels, LMAs, and ETTs. But the main 2 that I think you need to know really well are the ones that we have on screen right now. So we'll talk through oropharyngeal airways. They might ask you, how would you measure this airway? So I've just put a good way of memorizing it, which is thinking about hard tissue. So measuring from the midpoint of your incisors to the angle of your mandible. That varies with your nasopharyngeal, which is soft tissues. So from the tip of your earlobe to the tip of your nose. Now, when you're deciding what airway you would actually use, a good way that I was taught in med school was that you would initially try an oropharyngeal airway. If the patient tolerates it, that means that that is the one that is most likely appropriate for them because their GCS is quite low. It's going to be less than or equal to 8. And at that point, you're very concerned, you're calling 2222 for an anaesthetist to get there as soon as possible. If the patient, when you're inserting the oropharyngeal airway, you might also hear it being called a Goodell. If the patient starts to gag at that point, the gag reflex has been activated, and that means that their GCS is higher and they're more conscious. So at this point, that's when you would try a nasopharyngeal airway. A few things to look out for and scenarios where you wouldn't use a nasopharyngeal airway is when you're concerned about a basal skull fracture. And so the image on the right just shows the sort of signs that we're looking for, so sort of ecchymosis around the periorbital area and just behind the ear as well. Also, you might want to ask at this point or check if the patient is on any anticoagulants, because again, it's sort of high risk if you were to use a nasopharyngeal airway. Now, in the interview, they won't ask you to reel off everything, but they could ask you sort of any one of these details dependent on the scenario.
Okay, sorry about that. I was trying to unmute myself with the shortcut before, but it was causing problems. So next, after A, the next thing you want to think about is the breathing. It's the next most important thing. If the airway's patent and you're happy with that, then you can start looking, is there any obvious signs that you can see just by standing at the edge of the bed? So cyanosis, work of breathing, have they got a significant cough? Are they bringing anything up? You can then think about what parts of the respiratory exam that might be useful. So that's looking at things like tracheal position, is it deviated, the chest expansion, how much they can expand their chest, whether it's equal, and percussion, whether they're hyperresonant, whether there's any dull percussion or stony dull percussion. And then listening and just sort of what you hear, whether there's bronchial breathing, whether there's parts of the lung where the sounds are reduced, or whether there's wheeze or any crackles present, and especially knowing where they're present as well, whether it's sort of global wheeze or crackles, or whether it's in a particular part, and also whether that sound is occurring in inspiration or expiration. In terms of observations, some of these you might already have to hand if you've asked a nurse to perform them before you get there, but things like that's very important is the respiratory rate and their oxygen saturations, and how much oxygen they're on. And usually in an emergency scenario, if their oxygen saturations are low, you would put most patients on 15-litre non-rebreathe. I think even if they're a known retainer, often it's best to put them on a high amount of oxygen, because hypoxemia can kill someone faster than hypercapnia. Sorry, so you would first put them on a high amount of oxygen, and then you can reconsider whether you need to reduce that later based on their oxygen saturations. And also, if you're worried about their oxygenation, you can think about doing an ABG. And that's really the only time that you would pick an ABG over a VBG. If you want to have a look at sort of how well they're oxygenating and whether they're retaining carbon dioxide. You can get quite other important information from an ABG, which can be useful later on, like the glucose and the lactate. And then further investigations that you can think about. Quite often, most patients, especially if they're having a problem with their breathing, you'd like to order a chest X-ray. And then in terms of treatment, the main thing that you'd be starting on most patients, especially if they're having trouble breathing, their oxygen saturations are low, is starting them on oxygen. And like I said, most patients you would start, if they have low saturations, on 15 litres non-rebreathe and then titrating it down. And at this point, you can also think, based on what differentials you have, whether there's any specific treatment you want to give right away. So if you're suspecting someone's having an asthma attack, they're a known asthmatic, you can think about just giving some salbutamol nebulizer or ipratropium nebs. If at this point, which to be honest, you may have came to the conclusion in airway, if you're really suspecting something like anaphylaxis, you can give adrenaline.
Sorry, I'll just address one of the questions in the chat before we move on to C. Somebody's asked if in London's interview, are you asked to first prioritise and then conduct an A to E? So I'll answer this as I'm the London AFP. Basically, they can ask it in any way that they want, but it's pretty much an unspoken rule that the structure is you talk about how you would rationalise prioritising the different patients in the scenario, because there'll usually be more than one, and then talk through your A to E management from there. If they've seen enough of your A to E, then they may cut you off and interrupt you with questions and grill you, which is what happened for me. I only got to C. and then he started grilling me. So yeah, the typical structure is you rationalise what you'll prioritise and then delve deeper into one of those patients. Okay, is that on to Hannah now?
Yeah, perfect.
Great.
Yeah, and just to add on to what Davina was saying, I also had a Northwest interview, and with them, they didn't focus so much on the prioritisation, and it was more a single A-to-E. So I think just be prepared for any scenario. And I think even if it is just a simple A-to-E that you get given, it doesn't hurt to say sort of the prioritising things that we said before. I think it just helps you to come across better. Okay, so moving on to C, we'll go through it in the same structure that we've been going through all of it in, but then there's also a good way to sort of remember it if you ever forget this on the spot. So the things that you're looking for is sort of the patient's skin color, looking at how well perfused they are at their fingertips, but also centrally, so looking for any signs of any peripheral or central cyanosis. You also want to address hydration status, so looking for dry mucous membranes. That sometimes can be a difficult thing to actually see, but it's just a good thing to say when you're working through it. Looking at the JVP to check if that's elevated. The things that you're feeling for at this point are the temperature, so again, assessing the patient's perfusion. Adding on to that, you want to check the capillary refill, so pressing down for 5 seconds and hoping that it reperfuses within less than 2. You also want to check for pulses. Now, when you say this, don't just say you want to check the patient's heart rate, say that you'd also check central pulses. That's quite an important thing to say, and that you're assessing rate and rhythm. Then the things that you're listening for are any sort of added heart sounds, so any murmurs. That may not be common that you actually see that in a scenario, but that's just something, again, sort of a bit of a tick box exercise. Now, the main interventions, the main investigations, and observations that you would do within C are your basic blood pressure, an ECG, maybe an echo. If you do feel like an echo is necessary, justify why. You also want to get IV access. Now, that might be for taking bloods, but also giving treatment, which we'll come on to. Now, I think in medical school, I think everyone gets quite used to an OSCE scenario is reeling off all the different bloods that can be taken, so just saying FBCs using these LFTs. But I think it's really important that when you have specific differentials in mind, say the specific bloods that you would want, because they can very easily ask you to justify why you're taking that particular blood. So if you're saying D-dimer, say why you're taking that. Don't just say the patient's unwell, I'm going to take every single type of bloods under the sun. You need to sort of understand each intervention or investigation that you're doing. I think another important thing as well is to understand the difference between cross-matching and a group and save. So cross-matching is what you would do if you want to see what blood type the patient is and you think that they will need a blood transfusion. A group and save is what you're doing if you're sort of taking the patient to theatre and anticipating that there's going to be significant blood loss. Also, under investigations and observations, you want to catheterize the patient. Now, with this, you will be monitoring urine output. You can also do urinalysis, and then I think a very commonly neglected thing is doing a pregnancy test in females. Well, we've just lost the slides.
I think Matt's just texted me that his laptop's just crashed, so let me just share the slides instead.
Thank you.
Sorry about that. Okay, slideshow. Can we see this okay? Circulation screen?
Yeah, perfect, that's showing. Thank you.
Great.
Okay, and then so moving on to the treatments that you would do at this stage, you would know from the blood pressure whether the patient needs fluids. So know your standard 500 mils, 0.9 sodium chloride over 15 minutes. But also remember that if the patient is elderly, to look at the demographics of the patient, you would potentially give half of that dose, maybe give it over a longer time. During C as well, that's sort of the stage where you would be considering doing your sepsis 6 if it's indicated. So don't just do it for anyone, but if, let's say, the patient had a temperature at this point, a low blood pressure, those sort of things, then that's when you would do your sepsis 6, which I've just listed there. So the blood cultures would have been taken with the bloods that you've just done. The urine output, you'd have that from the catheter that you've just used. The fluids, you would have just given that now. The antibiotics is the additional intervention that you can do. Lactate, you would have from your ABG in the previous section, and then oxygen treatment, ideally you would have given that back in B. So most of sepsis 6 has actually been done. It's just sort of the little bits that you're filling in at this point. Also during C, so like we said, you can give drug treatment. So that might be your standard antibiotics for sepsis. So say that you would refer to the local hospital guidelines, look on microguide, or you might need to give sort of literally any other drug treatment for whatever the condition could be. So it might be cardiac drugs, it might be something else.
Okay, sorry about that. I think my laptop decided to conveniently crash.
No, that's fine.
So after that, the next thing we want to think about is D. And there's a few things that you'd usually consider at this point. The first thing is how conscious the patient is. You can use the either AVPU or GCS scale. I think in practice, most times people use the GCS. In terms of it's quite good to learn this off by heart. I can't actually remember it in practice. I just used the MedCalc app, which is actually quite a good way to learn it as well. And it's a good measure, especially if they've got a reduced GCS, they've had known head trauma. That can be an indication for like a CT head, and it's worth not just for interviews, but also medical school exams in general, is to know the indications for an urgent CT head and a CT head within 8 hours. And that can form part of it. The next thing is looking at the pupils. Are they the size of them, whether they're symmetric, and knowing sort of what you might think is happening if they're symmetric or like fixed at a certain size. So when you're thinking about if they're asymmetric rather, so if they're asymmetric, you can think whether there might be any sort of ocular nerve palsies, ocular motor nerve palsies, and thinking whether you need to do further imaging like a CT head, and looking at things like the direct and consensual reflex and also the RAPD. The next thing is also just looking at the drug chart. If they're coming in, they're more sedated than usual, their pupils are constricted, you can think things like opioid toxicity, or they may have had an overdose of certain sedatives or anxiolytics, which can be quite sedating as well. And that can cause them to come in with a reduced GCS. And the other thing is just doing a quick quick examine of the abdomen. So just having a look, is it grossly distended? Are there any surgical scars at all? Are there any obvious masses or hernias that are sort of poking their way out and you can quite obviously see? Then just have a feel, obviously general feel, looking for whether it's soft, tender, whether there's guarding, and knowing roughly where that is, and sort of the quadrants. And then also just having a listen if for whether there's bowel sounds or not. And then further investigations you do at this point, one of the most important things is doing a blood glucose. Often if you've done a VBG or an ABG, there'll be a blood glucose on there. Something quite important to consider if they've came in there a lot more tired than usual, they're not as responsive. It could just be that they're having they're hypoglycemic, and that can be quite easily fixed. If you're querying DKA, ordering ketones is also quite important. And then, as I mentioned before, depending on some of your findings, you might think whether there's need for an urgent CT head. So say if they've had an unwitnessed fall and they're on anticoagulants, that usually you need a CT head quite urgently. And then treatment that you can give at this point, like I was saying, with hypoglycemia, that can be quite easily managed, and depends whether they're alert or sedated as to what you would give, and whether they'd be safe to swallow or you need to give IV. Opioid toxicity, this can be treated directly as well with opioid antagonists such as naloxone. And then if you're suspecting DKA, it's about managing that, so things with like a sliding scale, giving fluids alongside that. So they're sort of the things that you'd consider at the sort of disability stage. But one of the most important things is doing the blood glucose, and that's something which I think can quite commonly be missed, and it's something which is very easy to fix. You can go on the next slide. Oh, Hannah, you're muted.
Thank you. Can you hear me now?
Yeah.
Perfect. Okay, so E is moving on to exposure and everything else that has been missed at this point. So a really good thing to acknowledge is that although you want to fully expose the patient's body at this point, you need to make sure that you respect their dignity. So a good way of acknowledging this in the interview is saying that you want to draw the curtains and utilise bed sheets where possible to sort of maintain that dignity and also prevent the patient from getting really cold. So the things that you're looking for are signs of injury. So look head to toe. So you're looking for any injury, any bleeding, any bruising, any CSF leaks, so any fluid coming sort of from the nose and the ears, and then a general look for any rashes. You also want to look for fractures. So a good way of assessing that is seeing whether you can visibly see any fractures, but then also just squeezing the long bones and then checking the stability of the pelvis. You can either do the focus abdominal examination, like Matt said in the previous section. If you haven't done it by that point, do it here in E. And the sort of extra things that you're looking for are any signs of bleeding, so looking for Cullen's and Gray-Turner signs. You also want to check, I think quite a common scenario in A to E is that it will be the sepsis 6 that you'll be doing, and it might be a post-op patient. So when you get the sort of little bit at the start to the little scenario at the start, if you see something that says this patient has just been in surgery 48 hours ago, the sort of differentials that you need to be thinking about immediately are, is this patient at risk of post-op sepsis, post-op bleeding, post-op infection? So at that point, you would consider looking at those surgical sites or any wound sites. You also want to, let's say you're querying somebody having a PE, you'd want to see whether you can see a DVT, so looking at the calves and giving them a squeeze for any tenderness, and also whilst you're there checking for any signs of edema. And then once you've done sort of all the clinical side of things, you want to gather as much information as possible. So that's a history from the patient, if they're conscious and able to give you that, or if there's one that's already been written up, a collateral history, looking at the patient's notes already and their drug chart. And the reason that you're looking at their drug chart is this patient may be incredibly unwell because they have a medical condition for which they've not been given their routine meds or they've missed a dose. So at that point, you can give sort of any interventions with that. You also want to consider giving any analgesia, and that's a really important thing, asking the patient whether they're in any pain and managing that, because that's something that can be done as and when it arises. You don't need to deal with the whole condition and then think about pain. If the patient says they're in pain, it's really important to do something about that. And then sort of any drug treatment that you've not given, so any antibiotics if it's necessary. And once you've done all of E, it's really important to say, I would now repeat my ATE assessment. But another thing that I would like to add as well is that after each letter, say that you would repeat your assessment of A. You don't actually have to go through it again when you're in the interview, but it's just important to say that that is what you would do. So anytime you make an intervention, you would make that intervention and then repeat whichever letter you're on. And then you would do a final repetition at the end of the whole A to E assessment. Yep, okay, so the next clinical scenario, I'll give you all a couple of minutes to read this. Oh,
sorry, I seem to not be able to mute myself unless I come off the slides. We do have a question.
Oh, yeah.
Which was, may I ask how does squeezing long bones help identify potential fractures?
So if you squeeze the long bone and the patient says, ow, there's likely to be a risk of a fracture. So it's just sort of a crude way to measure whether you would want to then proceed with any x-rays. Yeah. Okay, if there's any more questions, just pop them in the chat box. So I'll give you guys a couple of minutes, and if anybody wants to give it a go, or if not, I'll just choose someone and then we'll just work through sort of the A to E with the format that me and Matt have discussed. So I'll give you guys to about 45, 46. Okay, does anybody want to give this a go?
I don't mind going.
Yeah, perfect. Thank you. So what we'll do, so we'll just stay on this slide at the moment, and then if you just talk through what you would do at A, and then I'll give you a bit of information, then we'll move on to the next letter. Does that sound okay?
Yeah, that's great.
Okay, so do you want to talk through A for me?
Yes, so I'd start by assessing the patient's their airway patency, and I would do that by just introducing myself and just asking for their name and how they're doing. And if they're able to verbalize, I'd assume patency of their airway.
Yeah. Okay, so let's say this patient can verbalize, but let's say hypothetically they weren't able to. What would just be the quick things that you'd be checking?
So then I'd move on to the head tilt and the jaw thrust maneuvers. I'd check for anything obvious in the mouth, any objects or mucus or blood that could be suctioned.
Yeah. And then, so that's sort of the good way of thinking through it is look, feel, listen, measure, treat. So you've looked at those things. So under A, you can also feel for the breath. What sort of things would you be listening for?
So any added sounds, any wheeze, stridor. Yeah.
Perfect. And then, like you said, so with the treatment, you'd be doing the maneuvers. If once you've done the maneuvers and you need extra sort of assistance, what sort of things could you do at that point?
I'd call and the anaesthetic team. Yeah.
Yeah. And what could you do before the anaesthetic team arrives? What instruments could you use to help you?
So the oropharyngeal or the nasopharyngeal.
Yeah.
Devices. Yeah.
That sounds good. All right. If we could just go on to the next slide, please. Yeah, okay, so this scenario, the patient is verbalizing. So we're happy that the airway is patent. So if you could move on to B, what would you do?
Yeah, so with B, I'd like to take a look, listen, feel approach. So in terms of looking, I'd check whether they're using any obvious accessory muscles when breathing, whether they're calm and comfortable at rest. And in terms of feeling, that's actually a bit tricky.
That's right. I'll give you a bit of information as we go along. So let's say there's no signs of when you're looking, there's a little bit of extra work of breathing. There's no signs of cyanosis at this point, and there's no cough that you can't see the patient coughing. The things that you're feeling for. So in a normal respiratory examination at med school, what kind of things do you feel for?
I mean, you could percuss.
Yeah, so percussion is one. So you get a dull percussion.
Whether the trachea is central.
Yeah, okay, so the trachea is centralized.
And chest expansion, whether it's equal.
Yeah, so that's equal on both sides and it's not reduced. Yeah, perfect. Okay, now what kind of things are you listening for?
I guess whether their chest is any dullness, resonance, stony nullness, hyperresonance, anything like that.
Yeah, so you'd percuss and then you can see that they're sort of dullness, that's fine. And then with your stethoscope, what kind of sounds, what are the key ones that you'd be listening
like any crackles, anything like that.
Yeah. Perfect. So the good way to say it is that you would auscultate the patient on the front and the back of the chest, making sure to also listen to the base of the lungs. So with this patient, you can hear a wheeze bilaterally and also bilateral coarse crackles. Okay, so you've done your look, feel, listen. So now we're on to measure. What are the things that you can measure in a respiratory examination?
So oxygen saturations, could do, I guess, like an ABG.
Yeah.
And yeah.
Yeah, and what else can you do that you don't tell the patient that you're measuring whilst you're doing your heart rate?
Their respirate, yeah.
Yeah, perfect. So that's the easiest thing that you can get done. And what's an extra test that you can do if you're really concerned about someone's lungs? What are you going to be doing?
Chest X-ray.
Chest X-ray, perfect. Okay, so if we just, Matt, if you could just show you the next slide. Yeah, perfect. So this is what we've got. So we've got the respirate is a little bit raised. Your oxygen is low. There's a dull percussion that we talked about. There's bilateral coarse crackles and a wheeze. So what they'll usually do in the interview is that they will give you some information from your investigations. So here you have your ABG results and your X-ray from the patient. So if you just take a moment to look at those, and then sort of what are you thinking that you might want to do as potential interventions at this point?
So their oxygen saturations are quite low, so I'd be quite worried about that. So I'd give them 15 liters on a non-rebreathable mask.
Yeah. And then having a look at the X-ray. Why don't we talk through a little bit about what you can see on the X-ray?
Oh God.
Just, it doesn't need to be anything fancy. Just generally looking at it, does it look normal to you?
No. So there appears to be like the tram track lines, I think.
Okay.
Right. And there seems to be some consolidation. White patchy. I would say bilaterally.
Yeah.
Yeah.
Okay, so we'll just add a little bit on. So you gave the oxygen, really good. One thing that we can do even before giving oxygen is sit the patient upright. So just changing their position. That can also be very effective if they're having difficulty breathing. So the X-ray, what the X-ray is showing is bilateral perihilar shadowing. It's also showing the blunting of the costophrenic angles. And you can also see on the right lung, can you see there's that line that shows that the fish is sort of filled with fluid as well? Yeah. And then finally, there are curly B lines as well. So looking at that X-ray, what kind of differentials are you thinking could be going on right now?
I guess there could be.
And anyone else, feel free to put it into the chat box function as well. So what kind of things you're thinking?
Yeah, heart failure.
Yeah, okay. Heart failure, yeah, heart failure, and you can see sort of edema of the lungs, can't you, at this point? So that's what we're dealing with under B, yeah, pulmonary edema. And that could be secondary to heart failure or something else as well. So if we move on to C, we'll keep it on this slide for now. But so tell me what you would think through when you're working through C.
So here with C, again, in terms of, I'd take the look, feel, listen, measure, treat approach. So in terms of looking, I guess, well, I guess more in terms of feeling, I would check their pulse, blood pressure. With the pulse, I would check rate, rhythm, character. I would check JVP. I would listen to the heart sounds, check for any added sounds, and perhaps do an ECG.
Yeah, okay. I forgot to mention this on the other side, but there's a good way of, let's say you get onto C. I think C is one of the ones where there's quite a lot to remember, isn't there? So I think what a good way that someone taught me last year was if you think of the body sort of as a C shape, starting at your arm and then going down your body like this, you can remember what comes under C. So if you start at your fingertips, you're thinking of looking for any signs of cyanosis. So pressing down on the fingertips, checking the capillary refill time. You can also check the temperature here. You'd also move on to then check the pulse. So you'd know the heart rate, the rate, rhythm, and character. You'd move on to the antecubital fossa. At that point, check the pulses there as well. You can insert any cannulas at this point, take any bloods that you need, and do a blood pressure. Then moving up to your neck, you're thinking about your JVP, looking again for any central cyanosis. And over here, you can also check for perfusion centrally. Then what you would do is then move on to the heart. So you're looking around the heart region. What you can do here is listen to any heart sounds, do your ECG, do an echo if it's indicated, and then you can catheterize the patient at this point as well if it's indicated, urine test, and pregnancy test as well. So that C shape is just sort of a good way of remembering it if the look, feel, listen, measure, treat to see it is quite hefty. So that's just quite a good way.
Yeah, definitely. Thank you.
You're welcome. So if we just go on to the next slide. we'll just see what the findings for C were. So we can see that the JVP was increased. The heart rate is also increased. There was a pansystolic murmur at the apex of the heart. The blood pressure was pretty normal. There was a gallop rhythm. The plasma BMP level was raised, and there are signs of left ventricular hypertrophy from the ECG. So what is that sort of telling you?
I guess it fits with the picture of the heart failure.
Yeah, exactly. So at this point, under C, is there any, so now you're sort of pretty confident that there's likely heart failure or pulmonary edema. We definitely know from the X-ray. At this point, can you or anybody else put into the chat function what sort of treatment we could be giving at this point? So you've sort of put in the cannulas, you've taken any bloods, but you also have cannulas available for treatment. Yeah, so we've sat the patient up, someone's saying, so we've done that. Yeah, perfect. So someone's mentioned it perfectly. So it's IV furosemide. So you're giving them a loop diuretic, 40 to 80 milligrams. So once you guys start revising the specific presentations that can come up, that is the sort of level of detail that you would need to know. So knowing a rough dosage and the method in which you'd give the furosemide is really useful. So even under B, you could say that you would give that furosemide, but let's say you missed it in B and C has given you that supporting information, that's fine for you to say it then. Okay, so moving on to D, what kind of things are you looking for under D?
So the GCS or AFPO score.
Yeah. The GCS is normal.
Normal. I check. Sorry.
Yeah. So the GCS is 15.
Okay. I check the blood glucose levels.
Yeah. So that's within normal range.
Normal range. In terms of.
So just think of it neuro exam. What would you do in your neuro exam?
Whether the pupils are equal and reactive to light. Yeah.
Yeah. So just remember PEL. So pupils are equal and reactive to light. That's fine.
And
I think that's pretty much it. You've got the main ones that sort of apply to this scenario. So just make sure you get blood glucose. This patient, you don't really need ketones or any sort of extra imaging at this point. So that's fine. Just keep it relevant to whatever the patient scenario is. Yeah, so if we could just go on to the next slide, please. Yeah, so D, there's no concerns. And E, what are you thinking about in E? And just try and make it specific to this scenario as well.
Specific to the scenario, okay.
Yeah. So, you would give the general things that you would look at, but then also just keep in mind what kind of things might I see in E and where would I be looking for them? Yeah.
So exposure.
Yes.
So I guess like rashes don't really apply here.
Yeah, it's all good to just rule them out, that's fine.
Maybe any like obvious scars around the chest. Any signs of a pacemaker or anything like that, I don't know. And doing an abdo examination so quickly. And yeah.
Yeah, no, that's fine. So that's really good. You covered most of it. So a good way for E is to sort of think of it head to toe. So looking for signs of injury, I suppose, anywhere and any fractures anywhere. Then you're moving down to sort of the abdomen. So you do your abdominal exam. Then think about sort of any infection sites, and then moving down to the legs, you're thinking about looking at the calves. Now, we mentioned that could be for DVT. In this scenario, where the patient is really likely to have heart failure, you're looking for signs of any sort of edema. So that's sort of the things that you'd be looking for in the leg region for this one. And really good what you mentioned, looking for scars at the chest. So with this patient, we could see that they did have a murmur, didn't they? So with it, I think it was on the previous slide, but this patient is likely to have had mitral regurg, and so they might have had a valve replacement at some point. So looking for any sort of specific cardiac signs, if you think it is a cardiac or respiratory presentation, is really good. Yes, if we can move on to the next slide. Yeah, so P. edema bilaterally. And that's pretty much this scenario. You did a really good job. And I think, like you showed, if you just work through it methodically, even if you don't get the diagnosis immediately, as long as you're safe and you react to the presentation that shows. So if something is wrong, do an intervention if you can. So like with the hypoxia, giving the oxygen straight away. That's really good. They may also ask you at the end, like, what do you think was going on with this patient? So how would you sort of summarize in a quick sentence what you think was going on?
So I would say that this patient is presented with acute shortness of breath and difficulty breathing. In a short sentence, I suppose. Just more like their presentation currently, or bringing in the background.
Yeah, so they would ask, like, what do you think is going on with this patient? So this isn't so much an S-bar. They might just ask you, what do you think is going on with this patient? So you would just sort of say why you think it is what it is.
Yeah.
Then at this point, they might also ask you, what other differentials could you come up with? But it's fine. We sort of discussed the sort of different ones, but just always have a few in the back of your mind.
Yeah.
With this one, though, it really is just pretty much heart failure.
Yeah.
You're thinking about pulmonary edema secondary to that, and you have a potential cause being mitral regurg.
Mm-hmm.
Does that make sense?
Yeah. Got it. Thank you.
Do you have any questions? If anyone has any questions, just leave them in the chat box and we'll have a look. Yeah. If we could just move on to the next one. So I'll pass back over to Matthew.
Just before we move on, I just want to raise that for London interviews, especially, it's not very typical that you would get a chest X-ray or ABG results. It's really up to the interviewer, depending on how they want to grill you, whether they give you any extra information or not. So if you practice with a friend, practice an interview where you give each other extra information and they have to adapt, and practice as well where you're just stony-faced interviewer giving nothing else away. Oh yeah, and the other thing I wanted to say was something that's really good for D, if you're concerned about patient's neurological status, is asking the nurse to do neuro-obs, and that just kind of shows that you know what that that you know what that is, and that it's important to monitor that for a level of consciousness, and it can give you better detail than a GCS or something would. Okay, so I'm going to pass over to Matt now.
Okay, so next we're just going to cover a little bit about capacity and confidentiality. So capacity is something which is quite important to know about. They could throw things related to capacity into your clinical stations, and it might be one of the three things that you have to, scenarios that you have to prioritise. And as an F1, it's something which you will come across quite a lot and have to carry out a lot of capacity assessments. Like on my current placement, I probably average like 1 or 2 a week, so it's quite important. And it's very important to know that it's time and decision specific. So you may have capacity at one moment and then suddenly regain it another, and so you have to constantly reassess it, and also that it's decision specific. So they may not have capacity to make a decision about whether they need CPR or whether they need to be discharged home, but they could have consent over whether they want to decline personal care or they want to decline specific treatments. And some of the main things when you're thinking about capacity is you have to assume that everybody does have capacity, unless there's a specific reason why you think that they may lack capacity, and then you have to carry out an assessment to then deem whether they have capacity or not. And you really have to try and take as many steps as possible to ensure that they're able to make a decision. And merely if someone makes a really stupid decision, that doesn't mean that they lack capacity. You have to carry out a full assessment, which we'll do in the next slide. So if we can just move over. Okay, so there's 2 stages to the mental capacity assessment. So the first is there needs to be some sort of impairment or disturbance of their mind or brain. And this can be a whole host of things. Quite often, people just assume that elderly patients don't have capacity. If they're just a little bit older, they're a little bit more forgetful. But that's not always the case. They usually have to have something specific going on which can cause a disturbance. And this can range from lots of different things, obviously things which would be quite obvious, such as dementia, but can go all the way through to things like if they have anemia, that can also affect it. Or quite recently, on my wards, there was a lady that had been admitted with an infective exacerbation of COPD, but had quite severe type 2 respiratory failure, which can also affect their mind or brain. So once you are thinking, do they have capacity or not? Is there something which is causing an impairment? If you think that there is something, you would then move on to stage 2, which is the functional assessment. Can we just pull that bit up? Great. So there's 4 stages to this. And basically, you assess these while just speaking to the patient. So you need to make sure that they've understood the information about the specific decision that is going to be undertaken, whether they can retain that information, and whether they can weigh it up and then communicate it. And quite often, this is just done where you'll have a discussion with them, say about the risks or benefits of a certain treatment and whether or not they're going to decline it or not. You then need to try and, to your best ability, to make sure that they understand that information. Give them some time. So often that means going away, coming back a bit later, seeing whether they can remember that information, and then also just questioning them about that information to see whether they are able to weigh up that information and the pros and cons of it, and also whether they can communicate it. It doesn't necessarily just mean through voice. It could be through writing, or even if they're able to nod or say like to yes or no questions. You can also communicate decisions through that. So this is something that's quite important to be aware of, because they could ask you questions around this, and it is quite useful for when you're practicing in the future. Can we move on to the next slide?
Just to add something here, if a patient doesn't have capacity and a procedure needs to be done, like emergency surgery and stuff, the consent form that you use for that is called consent form 4. I don't know what consent forms 1, 2, 3 are for specifically, but if they lack capacity, they use consent form 4. We also missed a question in the chat just about x-rays again. Would you go through A, B, C, D, E, as in airway, breathing, cardio, diaphragm, everything else, or would you just say what you see? So I think in my experience, the interview is probably too time pressured. I mean, in London, they don't give you a chest x-ray or an image anyway, but I imagine most interviews are too time pressured. Hannah, do you have any experience with that?
Yeah, I think with the Northwest one, it wasn't as time pressured. So they did give some investigation findings, and you were able to talk through them quite extensively, to the point where there was enough time for them to ask, is there anything else you want to add, a couple of times.
Okay, and in that case, it's probably good to follow a structure like talking about quality with right, and then going through systematically A, B, C, D, E for a chest x-ray. Whereas I suppose in the very rare instance, if you were given one and they decided to radically change the London interviews, I don't think it would be worth spending time doing that. I think you could say that you would systematically go through this chest x-ray in an A, B, C, D, E approach, but the most glaring finding is X. That's probably what you'd have to do for London.
Yeah, I think judge it on sort of the time as well that you feel like you have. If you feel as though there's a lot more that you have to say that's relevant in any of the other letters, and then, like Davina said, just say the most salient findings and move on.
All right, cool. We'll move on.
Okay, and also with capacity decisions, it's also very important to include family, especially next of kin, in the decision as well, because often if you're worried that they're lacking capacity, you then need to act in the best interests of the patient, and when you're making considerations like that, it's quite important to include close family members if possible, or next of kin. The next bit, I just want to talk a little bit about doles. I think this is something which I always found a little bit confusing, but it's essentially an amendment that was made to the Mental Capacity Act 2005. In the end, the Mental Capacity Act allows for restraint and restrictions to be placed on someone if they lack capacity and you need to act in their best interests. And this is called a deprivation of liberties, where essentially you're you're able to enact this if they're kept on a locked ward or a locked room. They're not free to go anywhere without permission or close supervision, and they're continuously supervised. And basically the DOLS is some safeguards that are given to patients to try and protect them, which we've outlined here. So that's just provide a representative who looks out for and monitor the person receiving care. They can challenge deprivation of liberty decisions through the Court of Protection. And it also means that this deprivation has to be reviewed regularly. And it's worth noting that this is slightly different than when you're sectioning someone under the Mental Health Act. So DOLS quite often is specifically around capacity decisions for specific decisions. So if it's discharge destination and you're needing to, say, move them to a care home and they lack capacity over where they're going, you would use a deprivation of liberty to then act in their best interests to choose a discharge destination that's most suitable for them. And the DOLS just helps protect the patient during that process. And it's also worth knowing, I think we haven't specifically covered it in the slides, but to know some of the common sections under the Mental Health Act that you might need to use. So things like a Section 2, a Section 3, Section 5.2, a 5.4, and a 136, I think are some of the common ones. And it's just useful sort of being aware who enacts them, whether it's just one person or you need multiple people, and how long they last for and their uses. But mainly the Mental Health Act is when you're specifically detaining someone to treat mental health, whereas a deprivation of liberty is usually for a specific reason if they lack capacity for it and you need to act in their best interests. I think sometimes that stuff can be a little bit confusing, but I think it's important to know when you're making decisions, especially with patients that lack capacity. We can move on to the next slide.
I just want to add here, sorry, that if you feel restraint and restrictions need to be used on a patient, there are obviously stuff you would do first before doing DOLS, and it's important to just state the obvious, like about trying to reorientate a delirious patient before jumping to using something like IM lorazepam to sedate them. So if you show that you know how to work through things in a practical way and a kind way to escalate through your different steps, you'd say DOLS is one of the later things that you would consider for a patient that is repeatedly at risk of harm to themselves and therefore needs to be restrained or supervised.
Okay, so the next thing to consider is also they could ask you questions around confidentiality and when you can and cannot disclose information. It's mainly worth knowing that confidentiality isn't absolute. There are certain situations where you can disclose information. I think the main thing is if you're asked to disclose information, the first thing you should always mention about doing is trying to get consent from the patient and deciding whether they have capacity to consent to that as well. And if they lack capacity, you can, and you can't wait until they are then deemed to have capacity. You can disclose information if the overall it is overall benefit for the patient. So it's important to weigh up, say, if a certain family member or friend of a patient is asking for information specifically about a patient, first thing you need to try and do is get consent from the patient. If you're not able to do that, you need to weigh up whether giving this information is beneficial to the patient as to whether you disclose that information or not. And there's also some very specific scenarios where you can break confidentiality without the consent of the patient if need be. And that's if it's required by statute, mainly for communicable diseases, whether there's a specific court order or whether it's in public interest. There are some of these where it's threat to public health, national security, you may not come across as much, but if it's whether there's preventing harm to a third party or preventing or detecting a serious crime, that may be where you have to disclose information. But I think it's also worth noting that if someone is coming asking for this information, it's always worth discussing this with a senior as well, because it's likely that they'll have a lot more experience around these sort of things and they can give you advice on when you should and shouldn't disclose information. But I think the first thing that's always worth doing is trying to get consent from the patient to disclose the information first, and then after you've mentioned that, then you can go down, or if they lack capacity, you can mention it if it's overall benefit for the patient, or if there's a very specific scenario where you need to break confidentiality, like it's affecting or risking someone else's life, or there's a third party, or for general health of the public. There may be certain times when you would breach that, but it's best to sort of talk about it in that way, where you would always try and get consent from the patient first before then working your way down the chain. So we can move on to the next bit. So it's also worth knowing how to just give a concise SBAR handover, because you may, if there's time in the scenario, be asked to just hand over as if you were, say, needing to speak to a senior to get further advice. So we'll just briefly go through what each section is. So firstly, when you answered the phone, you'll sort of state who you are, what ward you're on, and sort of give them a quick headline about the patient or what you're wanting to do. And this should really be trying to grab their attention and making them want to stay on the phone, because in practice, quite often when you call, especially other teams, people can be quite reluctant to take on work. So you want to try and get their attention and give them a reason to keep listening. And then you just want to give a bit of background, so a bit more information specifically about, say, why they've came in, any relevant past history, if your current differentials that you're thinking about, and current investigations that have happened so far. You can then give your assessment of the situation. So often, if you've done an A2E, you'll be talking them through the A2E, what you've done, and if there's been any changes subsequent to that. And then the recommendation is asking them what you want them to do and when. So say if there's a particularly sick patient and you're referring to one of your seniors, it would be quite often for them to either give you more advice or for them to come and see the patient. And it's quite important to try and get a time frame for when they're going to come and see the patient as well, because if you just say, we want you to see the patient, they agree, you hang up the phone, you don't know how long it's going to be until they turn up. And if they're particularly sick, you might want them to come and see them now, like whether it's in the next 5 or 10 minutes. So it's worth getting a time frame as well. So if we just move on to the next slide, I've just quickly made an example. So for the situation, you'd introduce yourself. Hi, I'm Matthew Burst, one of the respiratory FY1s. I'm calling about patient X, who's an 87-year-old lady who presented to hospital with sepsis, likely secondary to a community-acquired pneumonia. Give a bit more about the background, so that she has a history of COPD and hypertension. She's controlled on trimbo-salbutamol amlodipine, and a 2-day history of worsening cough, shortness of breath, and she's a known retainer. And then you talk a little bit about what you've done. So currently, she has a pulse of 130 and appears to be an AF. She has a blood pressure of 89/47 and a high temperature, and she's tachypneic, and is currently saturating at 90% on 5 litres. She has a cough that's particularly with green sputum and appears clinically dehydrated. So far, we've taken blood and sputum cultures. We've started some antibiotics, and we're currently giving a fluid challenge. And then at this point, you would explain, I would like you to come and see the patient as soon as possible. Is there anything else you would like me to do from now? And quite often they will give you some extra things that they want to do, and then they would come and see the patient. And I think a lot of times, especially for an FY1, they're quite happy if you're able to do your A2E assessment, order some relevant tests, whether it be an ECG or a chest X-ray, and then treat things such as oxygen desaturations if they're hypotensive, starting some fluids. And I think if you can get to that sort of point, found that most seniors will be quite happy. So that's just a little bit of an example, and we can go through trying an SBAR handover in the example coming up. So if we move on to the next slide. So we've got another scenario. Again, we can, if there's anyone that wants to volunteer, we can just talk through these 3, how you would prioritise them in your rationale, and then we'll perform an A2E assessment on which one is the most urgent. So I'll just give a couple more minutes, so in 2 minutes, just have a quick read through, and then if anyone wants to volunteer, we can talk through the scenario. Okay, is there anyone that wants to run through the scenario?
Hi, can I have a go at it?
Yeah, of course. What's your name, sorry? I can't see you on
Leslie.
Leslie. Okay, great. So we can just start off. Do you want to talk a little bit, just sort of your current thoughts with the current patients that we've got here, the three, and how, so what your thoughts are on each of them?
Okay, so so given that I'm an F1, these three patients, I think starting with the most worrying for me is the middle one, 68 years old with the new score. The reason of this is because the other ones are quite relatively quite either not very specific in terms of, for example, the first patient has not been passing urine, but I don't know, I wasn't given what sort of time period we're talking about. And with the third one, the patient with palliative care, I feel like this is kind of a concern that the patient wants to speak to a medical team, but we haven't got a medical reason. It's kind of the will of the patient in receiving food and fluids. So so I'll prioritize the second patient first, and then the first one, and then lastly the third one.
Okay, great. And like you were saying, with the first patient, there isn't that much information there, and the same with the second one as well, that there's not a huge amount of information there. So is there anything more you would want to do on top of this to make your decisions?
Yeah, so in the meantime, probably because we're working in a team, so I can first of all ask about the second patient with regards to, actually I ask for support in terms of giving oxygens and meeting her oxygen requirements, and then I also obviously call the nurses or anyone in charge to have understanding of what the concern is regarding the first patient.
Yeah. That makes sense. So I think for 1 and 2, you can definitely think about getting an SBAR handover to get some more information. So say with number 2, although the new scoring is 6, depends. You want to know what their new scoring in, and then just having sort of a better picture of what the oxygen G saturations are. Are they currently on any oxygen? How are they like clinically otherwise? Because although like a new score is an okay indicator that's of someone's clinical picture, each patient is individual, and 2 patients scoring in news of 6 can be very, very different.
Okay.
So getting some more information for that, and again with the passing the urine, you were correct. You didn't really know how long it had been. So again, just getting a bit of a handover from the nurse. How long has it been since they've passed urine? Are they in any pain? Are there any signs and symptoms associated with this that might hint towards whether they're in urinary retention or not? It's also worth noting that often nurses can perform a bladder scan, which allows them to determine how much fluid roughly is in the bladder. And it is also worth noting on that we've mentioned previously about the fact that you are part of an MDT. Decisions around catheterization are also can be a nurse-led decision. So it can also be up to their discretion whether if they're worried that someone's in retention and they need a catheter. Nurses are also able to make decisions around that.
Okay.
But I think the way you've prioritised it is quite good. If the nurses are particularly worried about the relative for number 3, in that, say, the relatives being quite disruptive, you could consider speaking to another member of your team to see whether they're free to speak, depending on their workloads. But yeah, I think the way that you've prioritised that is quite good. I think the main thing is just making sure that you get more information about each of them, and then using that as well. But I think the order that you've picked is very sensible, but just making sure that we get more information about, especially the first 2, around the clinical picture and how they are, as to whether you need to make an intervention now or they can wait until you've seen the other patient. So I think number 2 is probably the one that you would want to see first. So we can, do you want to talk me through how you would perform an A2E assessment for this?
Yeah,
patient?
sure. So A2E assessment, first of all, introduce yourself, wash your hands, and then I'll go on over to A. So try to speak to the patient, see if she's, just to check her airways patent. Is there any information on that?
Yep. So if we can just move on the slide.
Okay, so she's verbalizing. So I'll move on to B. So I'll probably check on the bedside, at the bedside, and check for her comfort level, if she's awake, and if she's diffusing the color of her skin. I can observe that. I can observe the rate and the pattern of breathing, such as what we said before, like work of breathing, any accessory muscle use. And I can look around and see if there's any, if the oxygen supplement administration has been given, and check what sort of level she's on. So I think that's B. I can also check for and I'll move on actually. So C. So check for blood.
We'll just speak a little bit about B first. So I think you were correct with some of your assessments. I think that the best way to think about it, like we mentioned before, is look, feel, move, measure, treat.
Okay, yeah.
So done some things with looking. With feel, you can consider looking for things like tracheal deviation, percussion, whether they're hyperresonant or dull to percuss, whether chest expansion is equal bilaterally or not.
Yeah.
And then also just having a quick auscultation to see whether there's any sounds that you can hear. And then are there any sort of other investigations you would like to perform at this point? I think you'd mentioned a little bit about oxygen saturations. Is there anything else?
Again, so I might check if she. I kind of want to understand what sort of medication she's on, and perhaps.
Okay. Yeah, we can come to that. I think in terms of investigations at this point, you can think if they're desaturating.
Yeah.
We can think about doing an ABG.
Okay.
Which will give us a better picture of their oxygenation, whether they're retaining oxygen, so whether they're in type 1 or type 2 respiratory failure. And we can also think about doing a chest X-ray as well. So we just move on to the next slide. So here she's got increased work of breathing, using accessory muscle. She's tachypneic. On room air, she's on 87%. So we can give her oxygen, like you said. Her chest is clear. We do a chest X-ray and an ABG. What are your thoughts on the ABG and the chest X-ray?
So we're seeing a alkalosis pictures. Given the high pH, oxygen is less than normal, and CO2 is low. So I'm considering type 2 respiratory failure.
You're close. I think that the
respiratory alkalosis.
So respiratory alkalosis, yeah. I think she's in currently a type 1 respiratory failure. Type 2 would be if the CO2 was raised. But at this point, she is just tachypneic. blowing off a lot of CO2, which is low, raising a pH slightly. So you're correct, there is a respiratory alkalosis. And is there anything about the chest X-ray?
Not from what I can see. It seems to be normal.
Okay, that's fine. You're correct. It's a fairly normal looking chest X-ray. So now that we've done that, we've started them on some oxygen. Say our oxygen saturations are now improved. Is there anything now? Do you want to move on to the next part of it so we can talk a little bit more about C?
Yes, C. So first of all, so assessment. So measure her pulse and blood pressure. I'll check her capillary refill time, see if it's less than 2 seconds. Check for her urine output as well. To check fluid side of things. Check if she's also investigation standpoint. I can consider cannulating. Well, we've already taken blood, so we've gone past that. So we'll consider an ECG as well, just to check cardiac side of things. Yeah, there's not a lot of medical information from her, the background. So
I think that, yeah, the main thing is just thinking about look, feel, listen again. So just having a look at the hands, feeling the pulse, taking a blood pressure, listening to the heart sounds, and as well, when you're looking at the hands, checking whether they're warm, well perfused, what their capillary refill time is. I think you're correct. I think in ECG, you can quite often in it to be perform on most people, especially if they're tachycardic, because it can just give you some more information. So I think if we move on to the next slide. So she is tachycardic, her blood pressure at the minute is fine, and her heart sounds are normal. She's warm and well perfused. Her cap refill is under 2 seconds. Her ECG shows sinus tachycardia. If you just ignore the rate of the ECG, I couldn't find one that wasn't. I think that shows about 150 beats per minute, but it's not that much.
okay.
And it's also just noting, I think it is included here, but we can think about it later on, is that there's pitting edema present up to the knee. So at this point, are there any other interventions that you might want to give?
So she seemed to be having an AF, if I'm seeing correctly. I don't think I can see the P wave. Or is I think so one of my differentials would be AF.
Okay.
Yeah. So
Sure.
consider rate control. Rate control.
Okay, I'll just, I think this ECG, there's a bit of background noise, it's quite difficult. I'll just say that the patient isn't currently in AF.
Okay.
So it's just showing sinus tachycardia. So I think at this point, in terms of if we're thinking of things about fluids, there isn't really much indication. Blood pressure's fine. She's a bit tachycardic, but the blood pressure's okay. She's warm and well perfused. Her cap refill's good. Currently, I don't think there's any indication for fluids, and I think it's worth when you're talking through this is highlighting that and showing that you've been thinking about that. So even if things are normal, just be like, at this moment in time, the blood pressure is okay. She's not showing any signs of hypovolemia. So currently, I wouldn't
intervene.
There's no need for a fluid challenge.
Okay. So
should we carry on with the A2E assessment?
Yeah, sure. So moving on to D now. So checking her conscious level. So given that she's speaking to us, she'll be at least GCS of over 8. Obviously, we'll have to use the scoring and then check. So after is alert, I can also check her blood glucose to check if there's any signs of hypoglycemic. Yeah, so she's probably not having any seizures in the story here. So I think that's all. Yeah,
so it's just like what we mentioned in D, just thinking, like you mentioned about their consciousness level. So you rightly mentioned GCS, their blood sugars is always a very good thing to check at this point. And then if you're at all worried, you can do a very focused abdominal examination. So if we just move on to the next slide. So currently abdomen soft and non-tender, GCS is 14 out of 15, mainly just because she's a little bit confused, but her blood sugars are normal. So at this point, is there anything we can think, are there any differentials going through your head at the minute?
I think this is, she might have a, this might be physiological to her, depends if, how long this episode or the frequency of this goes on.
Mm-hmm.
Again, given the fact that the investigation seems to be quite normal, what we've done. Again,
yeah,
I
think you agree that there's no like very specific thing here, which can often happen, and I think then we'll just continue with the rest of the A to E, but then it's important to then sort of explore the history, because that can give you important pointers of where to go. So if we move on to E, is there anything that you would think about in E?
So perform head-to-toe assessment, check for any cuts in the skin, any fractures, potential fractures. Again, just always returning to A and just reassess.
Yeah, so it's always worth noting that, especially after every time you've made an intervention, is to then reassess. And like you're saying, if there's indications, so if the patient's had any recent trauma, doing a quick once over to check for any signs of any fractures or something is quite important. I think in this case, for E, we've had a feel of the calves, which are soft and non-tender. There is some pitting edema, but the calves themselves, they're not painful.
Okay, not painful. Okay.
So at this point, you've done your A to E. You've given oxygen, and say you've done your A to E. You've taken a bit of a history. So I'll just give you some information about history. So she's 68 years old. She's been having over the past couple of days feeling quite short of breath. She's been having some pain in her chest, particularly when breathing. It's very sharp. She's been saying it's about 7 or 8 out of 10. The pain doesn't go anywhere else. It doesn't radiate. And she hasn't really had any other associated symptoms, like no nausea, no clamminess or sweating. In terms of a past medical history, when you speak to her, she has had a previous MI and has a degree of heart failure following this. She's also got some breast cancer, which hasn't been treated, so that's still ongoing. She's going to be receiving chemotherapy for it. So given this picture, is there anything that's currently going through your head?
Yeah, so given that she's got a recent history of chest pain, so I'm considering, so first of all, perhaps a respiratory cause, so like PE, and cardiac side, I'm also considering like things like aortic regurg or stenosis, I think.
Yeah, I think they're valid. And I think as well, often you'll find in practice, while you're performing the A to B assessment, you'll be getting information from the patient as well. So you'll be taking a bit of a history at the same time. But I think they're some very valid things. I think the main things that will be going through your head are respiratory causes and cardiac causes. So PE, thinking whether there could potentially be a pneumonia. You've done a chest x-ray, which is making it less likely, but you still can have a bronchopneumonia with a normal chest x-ray. It's a bit more unlikely. But then, because we've also had a degree of heart failure, whether this is sort of an acute exacerbation of the heart failure, whether they're having another sort of acute coronary syndrome attack, whether it's a STEMI or NSTEMI, if they've got worsening chest pain, worsening breathlessness. So then what sort of investigations would you do based on these sort of differentials?
So first of all, carry out a CTPA of and also check her D-dimer scores.
Yeah, that's good. Based on the other differentials that you mentioned, is there any other investigations that you'd like to do?
Yeah, so perhaps a bedside echo, even though that's not a routine thing you would do. But
yeah, so I think if you're worrying about cardiac chest pain as well, the further investigations you can think of, bloods wise, is a
troponin test, yeah.
And you can also think about doing serial ECGs, so spaced out, just to see whether there's any dynamic changes evolving over time. And often, like Davina had mentioned in the structure, they can often throw some curveballs at you. So we'll say, you've seen the patient, you've taken a history, you're documenting your notes. The nurse then comes over to you and asks that they're a bit worried about the patient again, their oxygen requirement's gone up, and their blood pressure's gone down and they're a little bit more unresponsive.
Okay.
Is there anything that you would, based with this information, is there anything now that you would do to change your management?
Yeah, so I worry about her breathing. So given that she's got a deteriorating GCS, considering moving up the ladder of using airways like ET endotracheal and sort of airway protections. I also consider sorry, I forgot the first part of the information you've given.
So the nurse mentioned that she's became a bit more less conscious than she was before. She's hypotensive and she's requiring her oxygen requirement's gone up. So say she was saturating at 4 liters before, the nurses have had to turn it up to 8 to maintain her saturations. Okay,
so the P, it could be the P exacerbation, and throwing a clot off. Would you do an urgent? Yeah, I don't think I remember the intervention for that.
That's okay. I think
regulate and kind of thrombolize.
So if we just break it down, so you're currently, one of your working diagnoses here was a PE as well as cardiac chest pain.
Yeah.
If they're becoming more hypotensive, requiring more oxygen, obviously this is a sign that things are getting worse. In terms of these new signs, they've increased the oxygen, so the oxygen saturations are now okay, but now they're hypotensive. So one thing we'd want to do is re-perform the A2E, especially looking at C.
Okay, yeah.
And given the fact that the patient's hypotensive, we may need to give some resuscitation fluids. Before, she did have a previous cardiac history with some heart failure, so we'd need to be careful with resuscitation. So do you know how much you would give in a patient with heart failure?
I think it's 25% of, or 20, or even going lower than that. I think 20.
So I think with resuscitation fluids in a patient without heart failure can give it in boluses of 500 mils. Yeah. In heart failure, you just want to be a bit more cautious, giving 250 ml boluses, and also reassessing the patient in between to make sure that their breathlessness isn't getting worse. There's no signs of fluid overload. And at this point, because the patient is becoming more unwell, especially if you're unsure what to do and you feel out of your depth, the most important thing, because they're wanting to check that you're a safe FY1, is involving a senior early. And also, in this case, if you're worrying about a PE and they're showing signs of shock, that could be a sign of a massive PE, which is a medical emergency. So depending on the hospital you're at, say where I am, if they're news scoring more than a 7, you can put out, or if you're just worried about the patient, you can put out a medical emergency call through 2222.
Yes.
And quite often, most hospitals, if you're very worried about a patient. Most hospitals won't be annoyed at you putting out a medical emergency call, even if it isn't an emergency. So I think if they throw a curveball, you don't know what to do. The main thing is making sure that the patient is safe. If there's any changes that you can manage, like with the hypotension, is managing that and involving seniors early as well, especially if the patient is deteriorating. So just remember that as well. Involving seniors early is not necessarily a bad thing, especially if you've implemented some changes and you haven't been successful and you're sort of a bit lost with what to do. Involving seniors early is never a bad thing. Does that make sense?
Yeah, thank you very much.
Cool. So we can, if you want, we previously mentioned an SBAR handover. So say, given this, you can volunteer yourself, or someone else can volunteer if they want to try giving an SBAR handover. I'll imagine I'm, SHO or Reg, you're worried about this patient, you've bleeped me and want to get me to review the patient.
Does someone else want to go? So that I'm not taking on the opportunities. Okay, perhaps I'll go. So I'm the FY1, isn't it? So
yeah.
So I'm calling to an SH show. So I'm just introducing myself, where I am, what my name is, what my position is, and I'll say that I've got 68 years old female patients with a deteriorating oxygen saturation. So she's got a background of MI, heart failure, I think, and then she's currently in consideration for chemotherapy on the basis of her breast cancer. She also had I think it's 1 week, a few days ago, that she had episodes of cardiac pain of about I think 7 out of 10. She's been feeling she's been feeling racing heartbeats, so tachycardia and palpitation. So upon assessment, I've gathered that she's got a desaturating oxygen level, which we've intervened by giving her high flow oxygen, and in terms of fluid, we've also given her 250 mils of 0.9% sodium chloride, and that seems to be improving. It seems actually not improving. From an investigation standpoint, we've done chest X-ray, which revealed there's no pulmonary abnormalities. But the background, one of the differential is a PE with manifestation of PE and its symptoms. So I would like to ask if it's possible that you come down and perhaps review the patient and see if there's any further investigation that needs to be done and treatments. It's okay.
Yeah, okay. I think that was very good, and often the senior might be like, that's great, we can give another 250 ml bolus of fluid, just make sure that we recheck the blood pressure, and we need to book an urgent CTPA for this patient and call radiology ahead to make them aware. That could be a potential massive PE. I think you did quite a good job. Often with SBAR handovers, you just have to do lots of them to get fluid at them. I think the main thing is catching their eye early on. So when you introduce yourself, you can say, "Hi, I'm Matthew Burse. I'm one of the FY1s. I'm just calling about a patient that I'm very worried about and could be having a PE or massive PE."
Okay.
And that could just be your introduction. Then the background being a 68-year-old woman, the history of pleuritic chest pain and increased breathlessness. She has a background of heart failure, previous MI, and known breast cancer. In terms of the assessment that we've done so far, and then you just talk through your A, so you'd be like A, patent, B, we noticed increased work of breathing, her chest was clear, her oxygen saturations were 87% on room air, now saturating at 94% on 8 litres, and you would just go through A, B, C, D, E, saying what you found, what you've done, and then just explaining, I would like you to come and review this patient. I'm particularly worried about them. Would you come and review them in the next 5 or 10 minutes? Is there anything that you'd like me to do in the meantime? So it's just, I think the main thing is just practicing regularly with a friend and just being snappy at doing them. And it's also very useful for exams in the future because it's a very common OSCE thing.
Okay.
Cool, but you did a really good job.
Would you suggest that we make notes during each slides that in case of these presentations as part of handovers?
What do you mean, sorry?
In writing down notes during the interviews.
I think in your preparation time, it could, if they provide you with the means to do that, then there's nothing wrong with sort of getting your thoughts down on paper if you feel like that helps. During the interview, it might be too time pressured. Okay. I think the main thing is just practicing regularly and having the main thing is having a structure. It's why A to E is so good, because when you're put on the spot, all of your knowledge seems to go out of your head. So I think if you have a good structure and you've practiced that structure a lot of times, then you should be fine, even if you're under pressure and you don't know exactly what to do. So okay.
Yeah, thank you.
No worries, great. So just a little summary. The main thing is just going through a lot of the emergency section in the Oxford Clinical Handbook, sort of knowing them quite well, being able to know common drugs used in common emergencies. And a lot of this is just with getting fluent with your A to E assessment and S-bar handover is regularly practicing with a partner. That could be once or twice a week. The more you do it, the better. And also doing it timed. And just getting practice as well of setting scenarios for each other around prioritizing based on clinical need. And also preparing these for people is also very good practice as well, because you have to think about it yourself. And like I said, just practicing regular with a partner. There are some good websites for scenarios. I think one is called Medisense, which has a lot of different OSCE scenarios on, so it's good for OSCEs in the future, but it also contains scenarios of emergencies as well. And I think the Almost a Doctor website has good notes on clinical emergencies as well. So there's some good sources for some information, especially when you're practicing. But I think the main thing is just doing these things regularly and often. I don't know if there's anything else Davina wants to add.
So I've shared a website where we're uploading all the talks and the slides and the recordings, but I don't know if everybody's seen, I've added my Anki decks where I Ankied the emergency section of Oxford Handbook of Clinical Medicine, and that was basically my clinical revision for the station, because I blanked out the drug doses and things so I could learn all of those, what specific type of fluid and what type of insulin, whatever. It's all blanked out on that, so you can memorize those really effectively. I will send the link to that website. Or Matt, actually, I'm screen sharing. Would you mind sending the link in the chat for Medisense and Almost a Doctor? Sure. We have a couple of questions. If you suspected PE earlier, would you suggest in the A to E to request for D-dimer and CTPA, or would you wait till the end and suggest your differentials, then request them? I think you should say it in the relevant part of the A to E. So like, it would show that you've had the foresight to think about a differential if you say during CE that when I'm taking blood for this patient, amongst my full blood count using even LFTs, I would also take D-dimer because I have a high suspicion that this patient might have a PE. I would also consider at this point requesting a CTPA. And you can say that alongside with investigations for other differentials too, because in real life, that's what we do. We don't just investigate for one thing at a time. We actually cover a lot of bases, and we'll still do a chest x-ray and still do a blood culture for query pneumonia in case pneumonia without a temperature, for example. And somebody's also asked, do you know if you can take this abstract into the interview for London? So actually, I don't think you can because it's online. So the screen changes. I'm pretty sure you can't see it at the same time. So scribble anything down during your prep time that you want to refer back to. Any salient points in the clinical scenario that you need to comment on, and same for the abstract. Obviously, don't spend too much time transcribing because otherwise it's a waste of your prep time. Take over details that you want to raise. You will have a piece of paper to prep. The link in the Anki deck is on the website that I will share in the email. I assume everybody's on the mailing list. And the abstract, somebody's asked, will the abstract always be shared on the screen when you're answering questions? So no, I'm pretty sure last year I couldn't see the abstract or the clinical scenario while I was doing the interview. It's probably a good thing because you need to also have some of that interview body language, eye contact, and be engaging. And you might get distracted if you're trying to skim through that abstract again. So I would just assume that if you're being shown an abstract or a clinical scenario in the real interview, that you're not going to see it again. So any important details, jot those down. Yeah, so you do have to kind of remember everything that you want to bring up for the clinical interview, for example. Usually there won't be that much information in the clinical scenario that you will need to transcribe. But what I did on my piece of paper was just write in my A to E any particulars that are special about my A to E that I wanted to make sure I raised. So in this scenario, CTPA isn't part of your standard A to E. So I wrote that down, knowing that because I've memorized an A to E, I would still mention all the usual stuff you would mention for an A to E, like chest x-ray, ECG, blood cultures, all the other investigations. But anything special, I put down on that piece of paper. I hope that makes sense. If you could do feedback for us, that would be really good. It helps us see whether this course is helping you, and also helps us evidence that we actually taught you something. Everybody who does the feedback form will be more likely to get a mock interview. Any of your friends that couldn't attend today, don't worry, they can still watch a recording and do our feedback as well and not lose a chance. Because I know there were some other courses on at the same time today. And there will be more chances to practice these scenarios timed in more of an interview style format in the next few weeks when we run our tutorials. And then there will also be mock interviews where you can practice the whole thing together. I highly encourage you come along because it takes pressure off you for how many scenarios you need to prep for yourself, and also gives you extra feedback from someone new. And it's always good to practice as much as you can. I think I was practicing 2 or 3 times a week from September up to my interview date in November. Well, actually twice a week, not 3 times a week. I don't have that much time. So yeah, thank you for joining, everybody. I will send that link in Sorry, I accidentally quit the chat when I meant to just stop sharing. Here's the link for anyone else. Oops. I hope that works. Does that work?
I think it does. Let me check. Yeah, that works.
Ooh, ow. Okay, great. Thanks, Matt.
Yeah, no, thank you. Thank you everyone for coming as well.
I hope that recording is all right. Let me just stop it.